Hello everyone, I'm Dr. Hyppolite and this is your world. Today we have the privilege to have back on the show Dr. Gustave. Last time Dr. Gustave was with us, we spoke about neurological disorder. And today he's here to talk about
Pharmacology.
Welcome back.
Thank you. It's really my pleasure to be here. Thanks for the invitation because I have great interest in education, rehabilitation. I think the preventive measure in medicine will help a lot, especially in the community with not enough means to address your problem. So I just want to start by a few statements with people. We need to know there's maybe 100,000 injuries every single year in this country due to drug administration, to drug ingestion. So I think it's too many. We can help by decreasing those injuries. They involve death, actually. Around 60 years of age, people in average get maybe 7 medication. High blood pressure, diabetes, arthritis, a lot of medications. And then it's important to know good durations of those medications. But unfortunately, sometimes we have problems with culture, with bad habit. Mm-hmm. And that's another problem. You see, because medication should be individualized. Mm-hmm. And your neighbor did well with X medication doesn't mean you're gonna do well with the same medication for the same problem. It's important that people understand that part. I'm gonna tell you why.
So basically you're telling me, so if you're taking a medication for high blood pressure and even myself suffering with high blood pressure, I cannot decide to take your medication just because I cannot find my, or I'm running out of medication.
That's exactly what I'm saying. And like I said, once again, the choice of medication depends on so many factors. Your age, that will play a big role. Your ethnicity. Let me give you an example so you can understand. Like we're talking about blood pressure, we have 2 medications that work better in the Caucasian, like the ACE inhibitor, the beta blocker, work better for them, whereas Black people, we got the calcium channel blocker, the diuretic. Just based on the ethnicity, that can make a difference. What about gender? If you're male, if you maybe can resist to alcohol twice compared to a female, mm-hmm. because your level of metabolism is a little stronger, if I can use that word. It's not the right word, I'm sorry, but let's put it like that. I'm gonna give you another example what happened. That was in 2008 when America have 17 studies. They said if you give a group of medication called antipsychotic in an elderly with dementia, you increase death. They have 17 studies. Canada has 13 studies saying the same thing. Therefore, FDA said, you know what? We should not prescribe antipsychotic in the elderly with dementia unless we don't have another choice. I cannot believe in Korea, the finding is the opposite. They find antipsychotic protect people, the elderly with dementia. How come? It doesn't make sense if you don't understand what I'm trying to tell you. Medication got to be individualized. Mm-hmm. Your neighbor take that medication doesn't mean it's gonna work for you. Your mother suffer of high blood pressure. You suffer of high blood pressure, you more likely to have good result with your mother medication compared to your neighbor medication because you have the same genetic predisposition in some aspect. So we got some bad habit, like I said again. Sometimes people use the medication for the side effect, not so much it got good indication. I'm telling you, like the elderly, usually they use Tylenol 3 to sleep. Tylenol 3 is not to sleep, it's for pain. But one of the side effects is to make people sleepy. So they use it for sleep. I think that's a little dangerous, if you ask me. The topic is so important. I just gonna try to use a way people can understand what I'm saying. To me, pharmacology is a date between a foreigner and a local. Let me explain what I mean. Your body got one objective. The drug you're taking got another objective. Your body got only 100. I need to get that thing out. I need to do. You need deportation. I need to do.
You need to get better. You need to improve.
No, I'm talking about between your body and the drug you're taking. I said it's like a date two people's gonna meet, right? Your body doesn't like foreign substance. I'm gonna make everything possible to get that migrant out.
To reject that foreign object.
Oh yeah. And the drug said, I'm gonna try my best to change that aspect of you. So if you talk about medicine, what your body is doing, they call it pharmacokinetics. But for us, for today, let me tell you what your body is doing. It tries to get rid of that substance. Let's put it that way. Forget about pharmacokinetics, right? And what about the drug? What the drug is doing? Whatever the drug is doing, they call it pharmacodynamics. Forget about pharmacodynamics. What the drug is doing to try to make change, to modify things. I hope people can understand. Your body really want to get rid of the drug want to change your body. We'll put it that way. So how is going to get rid of the drugs? It's going to use a lot of strategies. Absorb the drug, distribute the drug, metabolize the drug, eliminate the drugs. 4 things. If I can repeat it again, absorption, distribution, metabolism, elimination. Absorption. How people absorb drugs? There's many ways people can absorb drugs. The most common one is by mouth. That's the one mostly we use. But sometimes we can use also by your rectum. Sometimes we can use also sublingual. You put the drug under the tongue. And I'm going to tell you why sometimes there is a different aspect to treat people. Sometimes it can be buccal. They put it in your mouth. Sometimes it could be parenteral. What does that mean? They're not going to use your mouth or your rectum. They're going to use maybe other way. It could be intramuscular. They give it in your muscle. It could be intradermis. Because your skin got a lot of layers. It could be just over your skin, some cream and then just put it on your skin. It could be intravenous. All of those modalities, they got the good thing and the bad things. When you take that drug by mouth, the drug got to go to the bloodstream, but before that, it's gonna go to the liver. The liver has a problem. If you come here, you're gonna pay tax. If I take 100 milligrams of drugs, when you get to the liver gonna take some. So you won't have 100 milligrams. So you need to know that.
So basically, it's a must when whatever medication that you take, he has to go through the liver first.
Depending on how I use that medication. Okay. If I use it intravenous, the liver is out. If I use it intramuscular, the liver is out.
Okay.
Yeah, some lingual, the liver is out because it goes. It depends. It depends of the way. For some people, I need to choose the best way to administer the drug. So if you have a liver problem, I'm trying to stay away from the liver. I'm trying to give you a drug that will not go to the liver. You got surgery if they remove your stomach, right? I need to find a way for that drug to get to the bloodstream without using your stomach, because it's very important to absorb the drug. It's very important you have those secretion of acid that help in the process. If you don't have that, that will make things so difficult. If you old, there's a little problem. The acidity
When
of
you
your
say if
body,
you old,
I'm
what
talking about
age
after
will you
60.
consider?
Usually after 60.
Okay.
So the acidity is different. So your absorption compared to the younger population will be different. The movement of your intestine will be different. It's slower compared to the young population. So when I'm gonna give you drug, if you're 25, you're 60, I cannot give you the drug the same way or the same dosage most of the time, because we're different. We're gonna assess the drug differently. So all those factors need to be taken in consideration when I'm giving you medication. Like I said again, people work at Kings County, not even doing some support service, but they are doctor in the block. If the neighbor got problem, they will go to them. And things like that, we need to prevent that. That can be very dangerous for why I just explained to you. So we're talking about absorption. Absorption will be different depending on your age, depending on your condition. If you have liver problem, if you have stomach cancer, if you have, it's gonna be different. It's not the same thing.
Okay, if I were to ask this question, I understand people take medication because there is a medical condition going on, and that's why it is important for people to take medication. But what will happen, if I were to be prescribed, to take this or that specific medication and I will not follow the requirement as it was indicated?
All right, you remember at the beginning we said there's 100,000 injuries in this country every year due to drug administration. That's part of it. We got a lot of people who discharge and will come back to the hospital. What's the reason? Exactly what you said. They don't follow the recommendation. And I'm gonna give you an example. It wasn't even there, but I have to do it right now. Let's say we got some people with psychosis and they have hard time to treat them, and they end up to give them a medication, the last resort medication called clozaril. And unfortunately, that patient is a smoker. When you discharge the patient, the first thing he's gonna do is to buy cigarettes, right? And when he's gonna smoke that cigarette, what's gonna happen? There's something called an inducer. The cigarette will be an inducer for the enzymatic system in your body. It's gonna make the system work more rapidly. You think your patient got clozaril at 10? However, because of the smoking, maybe it's at 2 or it's at 3. That patient will come back to you right away because of that interaction between the cigarette smoking and the medication.
What about if it was a different drugs? Let's say weed, alcohol, or what have you. So what
You
the
know what?
reaction will have been?
That's part of the presentation. We're gonna talk about that, about drug interaction.
Okay.
That's a very important concept. Drug interactions can be very dangerous. Very, very dangerous.
Yeah.
You're not gonna believe it. The most popular one I can tell you is you're gonna give somebody lithium with an NSAID. That's a big problem. You can lose that patient. So that interactions will create a lot of problem we're gonna discuss soon. So we're done with absorption. Absorption, like I said, is take the drug and get it to your bloodstream. That's what we call absorption. But the drug is not for the bloodstream. Maybe it's gonna go to a tissue that is repair, right? So will be going to distribution, right? How are you gonna distribute that drug? Once again, that depends of your age, that depends of your weight, that depends of your gender, of your ethnicity.
Your height as well?
Weight more than height.
Does your height has a wall?
Why are you talking about height? I'm short already, so I was saying that that will depend of your weight. What I'm saying is that many of those drugs are lipophilic. That means they will go to the fat tissue, right? You take the drug the first day, nothing happens. Second day, nothing happens. 1 week, nothing happens. That medication is not working. If you're not aware of that concept, they're gonna increase the medication, all right? But the medication is there. The only thing, the medication that works is the free medication, not the one in your fat tissue combined to protein such as albumin, right? And when the fat tissue is saturated, what's gonna happen is gonna reach back that drug to the bloodstream. And right there, that's intoxication because you got more drug available right now for action than before. So people need to take that in consideration. Let's say those drugs also are different. Some of them, they are absorbed from the stomach, some of them from the colon. You need to know that what drug is gonna go where, gonna be absorbed where. The distribution, one again, will depend of your nutrition.
But Dr. Gustave, when you go to the doctor for whatever medical condition that you may go to that doctor and medication was prescribed, they normally don't educate you or inform you. They just give you medication. So how people really gonna know about all of that you just mentioned?
That will be a different topic to discuss because I have to tell you, we really don't want to discuss that one. Is a lot of politics involved. In some countries, like Canada, they will do more prevention than curative medicine. They will try to prevent you to get sick. Cuba, they will try to prevent you to get sick. In America, you going to the doctor. In Cuba, the doctor is coming to you. That's a different thing, different result. They don't have money, they don't have the resources that we have, but the prevention pays so much, is cheaper and is more effective.
Exactly, because if I know that if you drink 2 cups of coffee, that can increase your blood pressure. So I will, instead of letting you drink 2 cups of coffee, I'll help you at least have 1 cup or half of a cup just to prevent you from getting in that condition.
Exactly, you don't need that condition. I don't need to wait until you get high blood pressure to treat you with medication for high blood pressure. What about if I tell you, you know what, maybe you should decrease your coffee? I'm telling you that even you don't have blood pressure, but I'm doing prevention. Telling you, oh, maybe a little exercise will help. You don't have high blood pressure. I'm trying to prevent that.
Yeah.
It's really cheaper compared to those medications. Once again, it's a little of politics. I don't want to do that.
So it's like before I let you go, so I remember one time I took a friend of mine who was pregnant at that time to the doctor, and she was prescribed a bunch of medication. And for whatever reason, she decided, how many that she was gonna take, and and so for how long? To my surprise, when she went back to the doctor after the 7 days time bracket that was given to her to take the entire bottle, and she told the doctor, I only took this amount. And the doctor was like, okay.
There's a lot of anecdote things like that. I got a good friend of mine went with high cholesterol. He was prescribed medication for high cholesterol. He said, not me. Let me go exercise. But the guy is good. He knows what he's doing. 45 minutes a day. He will do it no matter what. Went to the doctor, the cholesterol was good. Doc said, continue to take the meds. That's good. The guy never took the meds. He was exercising 45 minutes a day.
Yeah, so he knows that, by exercising or cutting down on whatever, like dairy. If you suffer with cholesterol, there are a lot of food, like greasy food, that you know that you have to stay away from. By staying away from those greasy food or dairy food, plus exercising 45 minutes a day. So that's even way much better than taking medication.
Yeah, because those medication guys are different. Don't get me wrong. I'm not saying I'm not against medication. Not at all. All I'm saying, we can do prevention. We can do a lot of non-medication approach. When they fail, when we don't have any other option, as a last resort, at that time, I will take medication. It can't be the first, your first step. That's the way I've seen it.
But oftentimes, you know, as patient, I may not know because I just go to your office and I explain what my conditions are, and you decide, hey, you may suffer from this, so you may send me, you know, to the lab to have some blood test one and what have you, and sooner or later, so medication may be prescribed.
I have no problem with that. But like I said again, sometimes we have to try the non-medication approach. They can
That
go
would have been
together.
best.
Of course. Anyway, no more politics. So I was a distribution. I said the distribution of the medication depend of a lot of factors. Your weight, medication will go to fat tissue gets saturated, release the medication, plus the one you're taking, so you get intoxicated. Because of that, you don't take consideration of your weight. If you malnourished, you don't have protein, you don't have enough protein. So most of the medication sometimes is combined to albumin, which is a protein in your blood. Guess what happens? If you don't have enough albumin to combine with your medication, you're gonna have more medication available for action in your blood, right? That's another problem also. So even your nutrition is part of the parameters you're gonna use to medicate it. And then about metabolism, what your body is doing the drug. Like I said, all you was trying to do is get rid of the medication. When the medication get to your body, the liver is gonna use a lot of strategies like oxidation, reduction, to make the medication more soluble, more water soluble, so it can eliminate that medication. But in the liver also, there's a system enzymatic that help with the metabolism. That's what I'm saying. When you take more than one medication, sometimes one medication can act on that system, make the system more active. We call it an inducer. Because it make that system more active, you take medication A that act on the system, make it more active, and take medication B. The system is gonna metabolize medication B rapidly. You're subtherapeutic, you're not getting the treatment. I don't know if I'm clear enough. There's a system enzymatic on your liver that help metabolize the drugs. But some drugs, unfortunately, interact with that system and can make the system work more rapidly. And then it's gonna neutralize medication B rapidly. You think you're taking the medication is not effective because of what I said. Those are inducers, right? But we got medication also, they are inhibitors. You know what they do? They slow down the system. You take medication A slow down the system. You take medication B. When you take medication B, it stays in the system longer than you think. You get intoxicated because the medication stays longer in your system. And we got very dangerous medication where we have that problem. Like a medication like warfarin.
So when situation like that occurs, will, as the patient or the person taking the medication, will I have an understanding of what's going on?
Not at all.
That's the worst
You're
part
taking
of it.
the medication, your problem remains. You're not gonna say, oh, that's because my cytochrome P450 is not working. No, nobody's gonna think about that.
So it's like, you know, if the medication is not working, now I go back to the doctor.
Increase the medication,
and say, so
we
it's
can
like
change
instead
it.
of considering or looking at the reason why the medication is not working, I'm pretty sure that the doctor probably know. But instead of considering, you know, to look at the problem, they will just increase the medication.
I don't know what they're gonna do. All I know, sometimes those medications interact with each other. I can give you a list of them that interact with each other. I give you lithium and the NSAID. You cannot give those two together. That's a problem. Valproate, oh man, you cannot give valproate with a few medication. There's a lot of them like that. Phosphentoin, phentoin, those medication, when you give them, you better make sure you know what other medication the patient is taking. Not only what other medication the patient is taking, you have to ask, do you buy any medication over the counter? Because some patients use their own things, maybe culture, from their culture, from the things. Those, there's a few of them I know. Have you ever heard of St. John or something like that?
No.
All right. Anyway, we don't. All I'm saying, medication can attack with medication, and I'm gonna tell you the number again: 100,000 injuries every single year in this country because of drug interaction. So people should be careful about it. So we're talking about the metabolism, and then after that, the excretion of the medication usually is by the kidney. What the liver is doing, the liver make the medication water soluble. Water soluble, the excretion can be easy. You send the patient out. Sometimes the liver use another strategy called conjugation. It add another molecule, another radical to the molecules, and can excrete it in your cell, things like that. So that's, like I was saying again, when you get to 60 years of age, taking maybe seven, 8 medication, if in at least your blood pressure, your diabetes, your cholesterol, it's gonna be on.
And if you reach that age, you are not taking that amount of medication, you should consider yourself as being lucky.
Oh my God, that would be rare, I think. That would be very rare. What happened with medication, the way they act, they use something called neurotransmitters.
Dr. Gustave, while you mentioned that, you say when someone reach the age of 60, so some medical conditions will come with age?
Of course, some are age dependent. If you live long enough, there's a few organs you're gonna have some deficit, some repair. It's like you have a car. Sometimes you need to change the starter. Unfortunately, we cannot go and change part of your body like that. They don't function the same way they used to. We have to admit that. Like I said, you remember at younger age, you can go to the supermarket, buy your thing. Now I won't take that chance. If I go to the supermarket, I have to write where I'm gonna buy. There's nothing wrong with that. It's age dependent. It's not working the same way it used to work. We have to admit that.
You're afraid that you may go back home and forget to
Of
buy
course, you're gonna
half
forget
of that.
Of
You
course.
need it to buy. Okay.
And another thing also, I'm a male. Our brain is got some issues also.
Compared to female?
Compared to female. I'm sorry. It's not scientific what I'm gonna say. Please do not quote me. Nobody should quote me. But we don't pay attention to details. I don't think male we take the female, they are better on that. I'm sorry, it's not scientific. All right. So I was saying medication sometimes use what we call the neurotransmitters, right? The neurotransmitters, it to make me do what I want to do. And then those neurotransmitters, they got so many steps they can mess up. I just want to take one so people can understand. Instead of taking a drug or medication, talk about it, I'm taking a neurotransmitters that use many medication, and then people can understand what I'm saying. Let's talk about sometimes there's a neurotransmitter called acetylcholine. Acetylcholine is a combination of a molecule produced by something called mitochondria in the cells, acetyl-CoA, and in my diet, I got something called choline. The combination with an enzyme gives me acetylcholine. All I'm gonna ask people to remember, acetylcholine play a very important role in memory, in learning, in concentration, in analgesia. That's all I'm gonna ask people to remember. Learning, memory, concentration, analgesia. What I'm saying if acetylcholine has some deficit or problem in the process, you may impair those 4 things I just tell you.
Not the 4
Memory.
of them at the same time.
It doesn't have to.
Okay.
Memory, learning, concentration, analgesia. And that will lead to diseases, right? Like we know now, if you don't have enough acetylcholine, we know what happens with your memory. We know that can lead to Alzheimer's, right? But it's not the only one. We have dopamine also, another neurotransmitter. I'm gonna discuss dopamine. I'm just saying, dopamine. If you don't have enough dopamine, you may have Parkinson, because it's important in the movement, in the execution of the movement. It's so important. I cannot describe how important is dopamine. That's the one that reinforces the movement you want to do, and that the one that stop the movement you don't want. Think about if you have a problem in the release of dopamine, what will happen? But we're not gonna discuss that one. This is a different topic. Like I said, is the physiopathology of Parkinson's disease. We don't need to discuss that. Let's talk about acetylcholine instead. That's very, very important. I told you those neurotransmitters, they help the organ to function the way. But acetylcholine cannot do the thing by itself. In order for acetylcholine to work, you need to react with something called a receptor. I'm going to ask people one again to understand there's many type of receptor acetylcholine can work with. We got 2 big group. We got the nicotinic one, we got the muscarinic one. All I'm saying that acetylcholine, when released, is gonna stimulate some receptor and then act on the organ. Let me give you an example. If you release acetylcholine, it's gonna interact with your heart. It's gonna slow down your heart. At the same time, on your lungs, it's gonna constrict the bronchioles. It's gonna increase secretions in your lungs.
So, what factors you normally consider when you prescribe medication to patients?
Make corrections of those deficits. If somebody got too much acetylcholine, I need to do something that happened. And unfortunately, the army, the people who's doing war, they know that too. They use a substance called ecotropat. The ecotropat will make you release a lot of acetylcholine. You remember I just told you acetylcholine make you increase secretions in your lungs? That's exactly what happened. They will die because it's like drawn in your own liquid. I was saying that's neurotransmitter gonna interact with some receptors and create some effect, like on your heart, on your lungs, almost everywhere. I think people should know what increase that substance and what decrease that substance. You know the best way? I'm gonna ask people just to remember, please, too much acetylcholine, remember, is water everywhere. Meaning what? Increased salivation, diarrhea, increased diarrhea, urination. Everywhere you're gonna have increase of secretions. Not enough acetylcholine, dryness everywhere, meaning constipation. Everywhere, dry mouth. Those are things you can see. Those are things that can affect people in not a very good way that people need to address. But I prefer that to be addressed by your doctor most of the time, because as you can see, those maneuvers, they are non-innocent maneuvers. Bad things can happen if you don't know how to do those things.
You know, by listening to you talking, Dr. Gustave, an idea just popped up. I believe that everybody should have the capability to basically, when they are prescribed with medication, to do research about the side effects, to do research about, the impact that can cause to their bodies.
That could be a good thing, but everything got good and bad thing at the same time. Because every medication they will give you will have a paper with many of the things I'm saying. But who's gonna read them? I know not me. So what I'm saying
And
is,
that's where we probably do the most harm to ourselves.
yeah,
Because the instruction is there for a
yeah,
reason.
yes, but because of politics, because of legal issue, the instruction, even the instruction, what they're gonna do? They're gonna put everything in that paper. Even something that happened 1 on 1,000,000, they're gonna put it on the paper because they don't wanna get sued. So sometimes you got people coming, I'm not gonna take that medication because it's doing that. But that happened rarely. And we got ways to address the problem. I'm not gonna take that medication. When I take the medication, I drool. I'll give you an example. Clothes oil make you drool a lot. No, but we got a way to address the
You
problem.
know why you mentioned that the patient come and say that I'm not taking that medication? I remember once I had a similar reaction. I had a bad cold. After a few weeks, I realized the cold will not go anywhere. I decided to go to the doctor and I was prescribed with some medication. And when I read the instruction, there were few side effects, but two of them were like stroke and heart attack.
Who's gonna take that medication?
And I'm like, oh, just for a simple cold,
Yeah.
so it's like, and I'm like, but I did take it one time. That one time, I had such a headache, and I'm like, you know what? Before that headache turned into something, I just waste the battle somewhere. So sometimes, I understand the
But
side effects of the medication can really
what they
scare
forget to
people.
tell you that happened maybe 50 years ago in one patient. That's what they won't tell you in that thing because they don't want to take any chance. They don't want to get sued. I told you, look at that. Usually it's a very fine, small characters. But I think people should get educated about the medication. The most common reason people will stop taking their meds is because of side effects. They are not educated about the side effect of the med. If I tell you, you know what, when you take that medication, it's possible you're gonna go home, you're gonna drool a lot. When you drool, I think it's better if the doctor forget to tell you that and you say, what happened? After that, look what happened to me. When you take that medication, you may have a little cramps. So I think that's better. You'll be better off to know it's a possibility you have that side effect than not knowing anything and
Yeah,
get
because
surprised.
you already got a heads up,
Of course, of course.
of what's gonna happen after you take that medication.
So once again, if people need to remember about that presentation, they need to remember there's 100,000 injuries in this country because of drug interactions. So people should be careful. And then medication got to be individualized. You work for your neighbor doesn't mean it's gonna work for you. And then about the side effect we discussed, please discuss that with your doctor.
And I have one question. So, can you describe your approach to manage medication side effect?
Yes, education.
Okay.
That's about education. I'm gonna tell you what's possible and what to do. The first thing to do is to call me. We have side effect.
Okay, I understand I can call you, if I experience any side effects. But while you're prescribing me that medication, you don't think that will be a best time to kind of educate me at least for 3 minutes, 2 minutes, or
Of
5
course, that's what
minutes?
I'm saying. So I'm gonna try to discuss with you the possible side effect, the most common one, and ask you to call. Don't try to address it by yourself. That's another thing. Please don't do it. Some of them are easily. Let me tell you about a dystonic reaction. That's something you get when you get an antipsychotic. It's a scary thing. You got a contraction of a group muscle. That thing can be treated in 5 minutes. A little Benadryl, a little congentin, after 5 minutes, you're okay. So, but if you don't know that, if you don't discuss that with your doctor, if you don't call your doctor to tell you what to do, that's a problem. Because, like I said, it's a little scary. If you say it, it's a little scary.
My next question, can you discuss the role of antipsychotic in treating bipolar disorder?
All right. The problem with antipsychotic, what they are doing, they try to modulate the dopamine. So when they block one type of dopamine, that's dopamine D2. That dopamine is going on 5 different tracks. You got one track that's an agostratal. We got the tubular and fundibular. We got 5 that you can block. That's why you got side effect, because actually, if you can have one selective one that can block the one that give you trouble, that will be better. But it will block all the track, right? All the 5 track. So that's where the side effect comes most of the time.
Okay.
Like you block the tuberal and fundibular tract. You know what's going to happen? We got people with galactorrhea, meaning milk in the breast, things like that. Male or female, right? So we don't need that. Is that the reason we give it? If we can find a way to give it and prevent the antipsychotic to block that track, that would be nice.
That would be okay. So my next question: how do you monitor and adjust medication regimen to optimize treatment outcome?
You start with the lowest level of medication. You start low, you go slow.
Break that down, more for
Yeah,
me to
meaning there's
understand.
no reason to go and start with the maximum dose of medication. It doesn't even make sense, because you don't know what was dose your patient will respond. Like I told you, medication got to be individualized. Some people respond to 1 milligram of Risperdal, example. Some people need maybe 4 milligram. That's happened. So I'm not gonna start with the maximum dose, and the maximum dose is the one usually come up with the side effect. That's the one who come with the side effect, especially at the beginning. There's no reason, there's no rush to go and start with a high dose of medication.
When you say especially at the beginning, it's probably because it's a foreign object,
Adjustment.
so it's like your body is new to it.
Not only that, it's foreign to your body. It's gonna do whatever it can. It said, too many of them. Let's react.
Okay.
It's a war. It's like a war now.
Okay, will you consider that is like taking drugs, for the first time? Or,
Of
or
course,
for the
that's
first
exactly
time?
what it is. That's
Okay.
exactly.
Okay, so how do we stay current with that new development and research in that area?
You have to go to those conferences when you got to continue to read the new papers, things like that. So that's the best way to do it.
Conference,
And with
and follow the whatever that recent research that was available in that regard.
Definitely.
Okay.
But no, that's very important. About research, you need to know exactly what you're gonna read. I'm sorry, you come up with it, I have to explain it, because that's very important. If you Google any type of topic right now in medicine, you're gonna see maybe 1,000, 20,000 paper. We're gonna see a lot of papers on that topic. Do you have to read all of them? No, not at all. Not all of them are very good papers. So you need to know how to choose a good paper. Let me continue to make sure. Some studies, there's different type of study. There's study like a case report. I'm gonna take an example. A case report is something you see in one patient, right? And you said, "Oh, I never seen that." Usually, when I give antipsychotic, I never seen that. Let me write a paper about it. It's a very weak study, because this is just one patient. You don't even know if what you're saying is because of what you did. That's just a case report. Can we take that in consideration? Yes. For what reason? To have further, better study to find out if what you saw was something valid, was something. So I'm not gonna read a case report. I don't have time to read a case report. What about a case series? A case series is more than one case you find. It's a good study. It's a weak study, and that can create a lot of trouble. I'm gonna give you a case in '79. There's 5 men in 3 Los Angeles hospitals. They develop PCP. They are losing weight. They are homosexual. People didn't know what was going on at that time. they are accusing community. Oh, those are those community. They are the one responsible. I'm talking about the beginning of HIV. They were so wrong in those case series study. They are wrong. They were wrong. They come with 4 H's, if you remember. That's so inappropriate, so mean to take a case series instead of doing further studies. Like I said, just publish that and make decision on that. No, that's wrong.
That could further down other people.
They have other type of study, like a cross-sectional study. This is like a picture between an exposure and an outcome. It's another weak study. I don't read them. Why? Because in order for me to say event exposure A cause event B, I have to prove that exposure A predate outcome B. If I got a picture cross-sectional, I cannot do that.
And sometimes some studies, so they they tend to repeat them. Before they even come out with the result, they will repeat them, like more than twice.
Sometimes they're trying.
If they're gonna come with the same.
That's
result,
what they have to do. That's what they have to do. That's exactly what they have to do.
Because that's how you're gonna prove the validity of the research.
That's exactly what I have to do. That's what I'm talking about. So a good study is not that common. A good study got requirement. It got to be a good clinical trial. When I got an exposure, right? I got an exposure. And I follow a population with that exposure. And I'm going to see the outcome for a different group. That will be a good. But even that one can be a wrong too. I need to have the right sample size.
Yeah, the sample size sometimes play a major role. Because if you conduct a research, and your sample size was like only 10 people or 20
it's not
people,
a good one.
So it's not, that was a weak sample size.
And my random got to be, my sampling got to be random. I cannot take my family to put on the study. I need to pick people randomly to represent the community.
Exactly.
So, once again, you're going to see a lot of study, but it doesn't mean all are good studies.
I respect your opinion,
Yeah.
I respect your opinion. Before I go to my last question, there was something you mentioned about drugs and drugs.
Drug interaction?
Yes.
Yeah, because that's what I explained. Some drugs gonna inhibit the system, the enzymatic system in the liver. You take another drug because that drug inhibit that system. It makes the other drug more available and can cause toxicity. Some other drug increase the rapidity of the metabolism, therefore make the other drug subtherapeutic.
I know few patients or clients who are taking psych medication at the same token use marijuana. What that can cause?
We don't. There is no good study. Patients. There is no good study between marijuana and psychotropic
medication.
It doesn't mean you're gonna see study. Of course, you're gonna see studies. All I'm saying, there's no good clinical trial with a good sample size to test what you said. That's what I'm saying. We know, once again, they have studies, but we need good clinical trial.
Is there any specific drugs that was tested?
Cigarettes, I just.
Or only cigarette?
No, not only cigarettes. I have cigarettes, I have alcohol, I got a few drugs. Right?
Okay. Let's address our last question. I don't know if you can walk us through any thought process when you're treating a patient with a complex medication regimen.
Like I said, two good treatments start very good therapeutic alliance. We're doing it together. I cannot do it by myself. You cannot do it by yourself. Let's try to do it together. That's the first thing. The complexity is gonna be addressed by both of us. Doc, you know what? I cannot take that medication on the morning. It make me sleepy. I can go to work. Okay, well, let's move it maybe at nighttime. He needs to, like I said, it have to be something both of us invest good interest, energy. It can be just the doctor or just the patient. I've seen that. He should know better to take that medication. No, he doesn't know better. That's why he's here. So we have to work with our patient to make them understand the importance of complying with a complex medication
So it
regimen.
should be kind of like your role as a care provider to help the client understand the importance of taking medication and taking medication as prescribed.
Exactly.
And if there is any change, like you said, the patient may feel like, oh, when I take the medication in the morning, it make me feel this way. So, as a care provider, you're like, hey, let's like you just mentioned,
What do you think
let's
about
try it
night?
at
What you do?
nighttime.
But I'm not gonna keep prescribing on the morning and you're not gonna take it. And then I don't even know. What time you think will be better? Or what do you think about the 8 p.m.? Let's have that choice together. Let's do it together.
But there are some medications that are required to be taken at night.
Because if that medication makes you drowsy, I think we better take it at night. You don't want to be drowsy during the day.
Okay.
That will make sense. But it's not an absolute rule. Those are things we can address, we can discuss.
Okay, that is pretty interesting. Anything else you want to add to that before we wrap up?
Once again, remember there's a lot of injuries with medications. It's not a game. Don't take your neighbor's medication. It may not work for you, even though if it works for the neighbor. And then once again, talk to your doctor. Try to have a very good team. That will be a team to address your issue, not individual things.
People should not try to mix their medication, with other people's medication, basically.
No, that's bad.
And so if you were to be prescribed to take a medication for a specific amount of time, you cannot exceed that time.
Not at all.
Okay, all of those are very important for people to know. Or what about if for any reason, so you prescribe me some medication to take for a duration of 7 days or 9 days. I travel, unfortunately, I didn't take that medication with me, but I already took that medication 3 times. Should I contact you to inform you?
That's it, yeah.
Okay.
Definitely.
Okay, because I'm like, basically, so it's like for the 4 days that, so it's like, my thing is like, should I continue or should I...
No, let's talk about it.
Let's talk about it. So you hear what Dr. Gustave said. So everything have a way to address them. So if you were to be prescribed, to take your medication for 7 days or 9 days, or you miss 2 or 3 days, don't say, you know what, so it's okay, I'll just add the other 4 days another time. No, have a conversation with your care provider. Because at the end of the day, we have our ways of doing things, but we have to consider the best way.
That's it.
It was a pleasure to have you, Dr. Gustave. Thank you for your time. So I know today it's a winning day for you to make it to the show, so it's well appreciated. Thank you so much.
No problem. Thank you.
Okay, so of that said, I'm gonna let you go. So it was a pleasure, having you watching or listening. Please don't forget to subscribe, leave a comment. I'll see you next time. It was with you, Dr. Beatrice Hyppolite, with your world.